So thank you, Dr. Saira, for the opportunity. And I'm going to be discussing the scalp blocks for craniotomy. However, before jumping to our main topic, I would like us all to nourish our brain with some important information. So the layout of my today's talk is going to be a few words about craniotomy, anesthesia-related challenges, types of craniotomy, utilization of regional anesthesia for craniotomy, the scalp block, and then I'm going to share few practical tips based on clinical experience, and then I'm going to conclude my talk. So basically, what is a craniotomy? In simple terms, it is just opening up of the skull temporarily, and then the bone flap may be placed immediately after the procedure or at a later date. The indications for craniotomy vary widely. They may include removal of a tumor, hematoma, or abscess, and the craniotomy may be undertaken electively, or the procedure may be urgent or emergent one. It can also be performed for clipping of an aneurysm, removal of arteriovenous malformation, VP shunt placement, revision, or removal. Other less common indications include stereotactic or neuroendoscopic procedures, epilepsy surgery, lobectomy, craniosynostosis repair, CSF leak repair, or placement of deep brain stimulators for movement disorders. Whatever the indication, the steps of a craniotomy usually includes preparing, positioning the patient, making the skin incision, opening up the skull, exposing brain by cutting off dura, correcting the underlying problem, and finally closing up the dura and the craniotomy incision. So it may seem straightforward, but the associated challenges, not just from the surgical point of view, but from the anesthesia point of view, makes this procedure a high-risk one. So talking about anesthesia-related challenges, the practice of anesthesia for craniotomy encompasses different clinical scenarios that require to be addressed in a dramatically different way. For example, if the craniotomy is indicated for a patient with traumatic brain injury, it is usually an emergency procedure and the patient is not fully optimized. If the craniotomy is being undertaken for intracranial tumor resection, the patient might be having some neurological deficits, seizures, or raised intracranial pressure. Neurovascular surgery may be related with increased risk of AV malformation, rupture, or aneurysmal rupture. While stereotactic procedures may require special attention, especially if the area is very close to some motor cortex or some eloquent areas of the brain. This chart shows the routine as well as some additional monitoring required in these kind of procedures. And it shows how much preparation and vigilance is needed for this type of surgery. Another point worth noting is the placement of Mayfield pins to secure a patient's head during neurosurgery. These pins are inserted into patient's bone, and although there are some potential complications like skull fractures, vascular injuries, and nerve damage, these are quite rare. The most important point to notice here is that these pins, when inserted, cause severe pain and are associated with sympathetic stimulation, and they require tampering with the depth of anesthesia. This is the Mayfield clamp device, and these are the actual pins that are inserted into a patient's skull. They may seem like a torture device, but this is what the neurosurgeons actually use. And depending upon the approach and the incision site that the surgeons are using, the patient is placed either in sitting, prone, lateral, or supine position. And accordingly, the position of inserting the Mayfield pins changes. For emergency decompressive craniotomies, the larger incisions are traditionally made. However, for stereotactic procedures, tiny markers called fiducials are used instead of the head frame. These fiducials, as shown in the picture, guide stereotactic radiosurgery, allowing for precise targeting of radiation beams. The anesthesia for craniotomy has significantly evolved over time. Among the key issues for this discipline is the harmonious management of pharmacological, clinical, and physiological variables. Intra-op management encompasses to address multiple patient-based as well as disease-based needs, both in the elective and emergency settings. This chart shows us some of the complications that may occur during or after an elective craniotomy, and the risk of complications increases if the procedure is being done in emergency settings. Out of all the challenges of a high-risk procedure like this, patient's disease state, routine, as well as special challenges that are associated with a craniotomy, pain has a huge impact in overall course and outcome in neurosurgical patients. Addressing and managing this single component appropriately has a huge impact on morbidity and mortality. When classifying craniotomy, there are few approaches. Sometimes we classify the craniotomy based on the indication, whether it is being done electively or in emergency setting, whether the patient is anesthetized or is wide awake throughout the whole procedure. If our approach is supratentorial versus the infratentorial approach, and finally, the location of incision. Talking about the location of incision first, there are a few incision types that the neurosurgeons make depending upon the underlying pathology. This picture shows the area to access the frontal lobes. And if both the frontal lobes are to be accessed, then a bicoronal or a bifrontal approach is used. This incision is also known as question mark incision, and it is used for temporal procedures. The incision is made posteriorly along the superior border of the temporalis muscle. This incision is for parietal lobe access, and it is known as posterior question mark incision, and it is usually a larger incision of all. Sometimes a modified approach is used to access the parietal lobes. A U-shaped incision is made and the patient may be kept in prone or sitting position to access the posterior parts of brain, cerebellum, and brainstem. The flap is retracted and access can be gained to these parts of the brain, or the incision can be modified depending upon the pathology present. This is the incision made to gain access to the terional region of the scalp. Sometimes the plan may include a craniectomy or a cranioplasty. In craniectomy, a skull piece is removed and is usually placed in the anterior abdominal wall and is decided by the neurosurgeon to be placed at a later date by the procedure of cranioplasty. Supratentorial craniotomies target the cerebrum, while the infratentorial craniotomies target the cerebellum and brainstem. This diagram shows the demarcation over here. If we need to access the cerebrum, then supratentorial approach is used. If the surgeon needs to access the cerebellum or the brainstem, the infratentorial approach is used, which is associated with more complications, more risk of not just intraoperative, but post-op pain, as well as this pain converting to chronic pain states post-operatively. Regarding awake craniotomy, it is not a new concept. Trephination of skull was one of the earliest performed surgeries, and in the prehistoric times, anesthesia was not available, and the trephination was done in awake patients. What is awake craniotomy? Basically, the craniotomy is taking place while the patient is wide awake and alert during the whole procedure. This is the layout of an awake craniotomy in the theater. The neurosurgeons work behind this screen while the patient is awake. The anesthetist is sitting here and monitoring the patient, and the anesthesiologist assesses the patient's higher mental functions as well as the motor and sensory functions. For example, like asking the patient to move all four limbs. And despite all the advanced gadgets available for monitoring intraoperatively, This form of monitoring the neurological status remains one of the best methods still in date. As you can see, the anesthesia machine is still over here in case it is needed. The indications for an awake craniotomy may be based on anatomical reasons like resection of tumors adjacent to eloquent regions or motor cortex of the brain. Physiological reason may include placement of deep brain stimulators for movement disorders, or an awake craniotomy may be done due to pharmacological reasons where we need to avoid certain drugs during brain mapping. Now, why do we need to keep our patient awake during the craniotomy procedure? Well, it maximizes tumor resection while preserving the neurological function because it is one of the most advanced and important kind of method to monitor the patient's neurological function. It also helps us to avoid all the inherent risks of general anesthesia and mechanical ventilation. There is reduced need of monitoring in ICU postoperatively. Awake craniotomy, when compared with craniotomy with anesthetized patient, is associated with fewer neurological deficits. It has shorter hospital stay. There is decreased postoperative pain, nausea, and vomiting, longer opioid-free period, and delayed request for rescue analgesia. Emergence hypotension is avoided. Decreased risk of nosocomial infections as well as thromboembolism due to early mobilization. And if post-op mechanical ventilation and ICU stay are avoided, it appears to be quite cost-effective for the patient and the hospital. Now, there are two techniques in which we can achieve a patient being awake during this craniotomy procedure. One is the monitored anesthesia care, where the patient is awake throughout, or at the most, some form of sedation is only used. While the other technique is asleep, awake, asleep technique, in which the patient is induced with general anesthesia. Then the patient is woken up in the middle of the surgery where the neurosurgeon needs to do the neurophysiologic monitoring, brain mapping, or resection of tumor. And then again, the patient is induced with general anesthesia until the procedure is completed. Comparing the two techniques, the asleep, awake, asleep technique requires general anesthesia. The airway of the patient is managed actively either with a supraglottic airway device or an endotracheal intubation. Patient comfort is reported to be higher with this technique, but the risk of airway complications is more with this technique. But this technique is suitable for patients who are either anxious, uncooperative, claustrophobic. This technique is also associated with wide fluctuations during these transition phases. So it needs quite tailoring of the technique for each patient individually. Looking at the awake throughout technique, the patient is kept awake with minimal sedation and the patient breathing spontaneously. However, the patient usually reports discomfort either due to prolonged positioning and having experiencing the postural ache, body ache, and the patient may become uncooperative in between the procedure. So the patient needs a lot of counseling, and this technique is suitable for patients who are cooperative and highly motivated. However, the benefit of, apart from the neurological assessment, is that the hemodynamics are more stable with this technique. When the world overall is using general anesthesia, why do we need regional anesthesia in the context of craniotomy? Well, this is not a new concept. The concept of scalp block was introduced by Harvey Cushing and George Krill in the early 19th century. And the technique of anatomically directed scalp blockade for awake craniotomy was first described by Gervin in 1986. In the same year, Sir Victor Horsley performed the first awake craniotomy to localize epileptic focus with cortical electrical stimulation. Studies have reported that approximately 80% of patients undergoing craniotomy are believed to endure moderate to severe pain following the procedure. Despite advancements in anesthesia and pain management, post-op analgesia in neurosurgical patients still remains suboptimal. This is partly attributed to the fear of side effects of commonly available analgesics, like increased risk of bleeding with the use of NSAIDs, or opioid-related side effects like excessive sedation leading to hypoventilation and hypercarbia, nausea, vomiting, leading to raised intracranial pressure, prolonged recovery times, interfering with neurological assessment post-operatively. And these may have disastrous complications, especially in the neurosurgical patients. These limitations highlight the challenges of achieving effective pain control in neurosurgical patients. The scalp block has gained prominence for its effectiveness in reducing post-op pain and maintaining hemodynamic stability. This method has been recognized as a critical component of multimodal analgesia strategies. Like any other regional technique, it leads to lower postoperative pain scores, reduced rescue analgesic requirements, a decreased incidence of post-op nausea, vomiting, a diminished need for antiemetic meds. Additionally, the time to first analgesic administration is significantly extended, and patient satisfaction levels are reported to be quite high. Sometimes studies have shown that the effect of a scalp block may last for up to 16 hours postoperatively, which may help with the rehabilitation process as well. This meta-analysis compares a lot of studies in two regards. One is placement of a scalp block before incision or postoperatively, and the second one is comparing the two techniques of either placing a scalp block versus scalp infiltration. So what are the results? Well, scalp block placed preemptively leads to significant reductions in anesthetic agent dosages, decreased adverse reactions and complications, and consistently lower pain scores during various intra and post-op stages. Furthermore, the reduction in opioid consumption observed not only decreases the risk of dependence, but also minimizes opioid-related side effects. When comparing scalp block technique with the infiltration technique, the scalp block appears to be more effective, associated with less use of local anesthetic solution, more patient and surgeon satisfaction, as well as a reduced risk of local anesthetic systemic toxicity. In essence, scalp block offers a more targeted and potentially longer lasting pain relief for larger areas because the nerves themselves are being targeted, while scalp infiltration is associated with depositing the drug in the subcutaneous tissue, which provides localized pain management of shorter duration. Based on research, this scalp block is recommended as a preferred analgesic approach. And this is the reason that despite having a history spanning over a century, scalp block has recently seen a resurgence in its use. Apart from craniotomy, what are other indications for placing a scalp block? It may include VP shunt placement, eyelid surgeries, removal of a dermoid cyst or a sebaceous cyst in the scalp region. In the emergency department, the scalp block may be placed for scalp laceration repair, removal of foreign body, and as already described by Dr. Umar, it could be also used, certain components could be used in chronic pain management. This is the list of the main nerves innervating the scalp. This is one side of the scalp that is being innervated by all these nerves, and these nerves are in pairs. So the other half of the scalp is supplied by the similar pair of these nerves similarly. Regarding the anatomy of the scalp, it consists of 5 layers, and the mnemonic of scalp is used to remember them. S stands for skin, C for connective tissue, A for aponeurosis, L for loose areolar tissue, and P for pericranium. Here you can see all the 5 layers, and these are tightly fixated by fibers to the outer table of the skull bone. This chart shows that all the 3 branches of the trigeminal or the fifth cranial nerve supply the anterior and lateral part of the scalp, while the greater and lesser occipital nerves supply the posterior part of the scalp behind the auricle. This chart shows the dermatomal distribution of each nerve. As you can see here, the majority of the anterior part of the scalp is supplied by a supraorbital nerve along with supratrochlear nerve. And up to the vertex, this whole area is blocked if we are able to block the supraorbital supratrochlear nerve. Then the lateral part of the skull is supplied by these branches, which is the zygomaticotemporal, auriculotemporal, and a small area of the scalp may be supplied by great auricular nerve, and the posterior part up to the vertex. This whole area is supplied by the lesser greater occipital nerves, as already described by Dr. Umar. Traditionally, we all know that all these drugs have been used for nerve blocks, but lidocaine would be a poor choice owing to its shorter duration of action. It is not a good choice to use for craniotomy procedures. The levobupivacaine is our best shot because it is the least cardiotoxic of all these long-acting local anesthetics, is highly potent of all them, and provides a long duration of anesthesia. But because of the availability issue, bupivacaine still remains the most commonly used agent for scalp block. Adjuvants are also used for scalp block, the most common one being the epinephrine. Not just it prolongs the block, but it also reduces the bleeding. The scalp is a very vascular structure, and the craniotomy incision may be associated with a lot of blood loss. So epinephrine provides this added benefit as well. Apart from that, dexamethasone, clonidine, dexmedetomidine, sodium bicarbonate, and magnesium, they all have their own benefits and inherent risk, and all have been described as adjuvants for scalp block in the literature. We have seen a lot of trend towards using ultrasound for nerve blocks or regional anesthesia, and scalp block is no exception to that. When comparing the two techniques, landmark-based technique is definitely based on the anatomical surface landmarks, and you only need a syringe and a needle to perform this block, and hence it is quite easy to learn. However, the accuracy is variable depending partly on the anatomical variations, but mostly on the skill and experience of the clinician. The risk of complications are a slightly higher when compared to ultrasound guided technique. However, with experienced hands, this is much faster to perform with landmark based technique. When talking about ultrasound guidance for scalp block, it uses real-time imaging to identify nerves and vessels. And you need an ultrasound machine with a high frequency linear probe, which is a very important limitation because it has cost restraints and the machines and these types of probes are not readily available. It also requires a lot of training and experience in sonoanatomy. However, the higher precision and real-time visualization leads to higher success rates and lower risk of complications. The block needs a little bit more time to perform under ultrasound guidance when comparing with the landmark technique. Coming to the technique of the scalp block. The nerves included are 6 nerves which supply the main innervation to the scalp. Out of these 2 nerves have already been discussed by Dr. Umar, although in the context of chronic pain, but the method to block these nerves is similar for a scalp block for a craniotomy. So I'm not going to discuss or repeat these. And we are going to tackle the remaining nerves one by one. The first one is the supraorbital nerve. In order to block it, we need to identify the supraorbital notch, which is at the supraorbital margin. You can identify this by either palpating it in the eyebrow region, but it may cause discomfort to the patient. The other technique is we ask the patient to open his eye and look forward. The point of the pupil coincides with this foramen, and we can identify the point of injection. Another method is to draw a line from the mid of the bridge of the nose and then move laterally about 2 centimeters. This is again going to coincide with this foramen. We usually place this block just above the eyebrow where the supraciliary fibers are less dense, making the injection a little bit less discomforting for the patient. Here you can see the point coincides with the pupil, and the area that is blocked by anesthetizing the supraorbital nerve extends up to the vertex. If ultrasound guidance is used, the probe is placed in transverse orientation just above the eyebrow. We need to identify the supraciliary arch, and the break in between coincides with the supraorbital notch. Here you can see the needle is brought in by the out of plane technique. We don't need to visualize the nerves because of their small size. We just need to identify the landmarks and deposit the local anesthetic. Here you can see that we are trying to localize the supraorbital foramen by the ultrasound. And once we identify the orbit, supraorbital foramen, we are going to inject our local anesthetic just above this foramen. You can see here the needle is being brought in by the in-plane technique and the local is injected. After injecting, the nerve may or may not be visible, and it is not necessary to visualize the nerves. Regarding supratrochlear nerve, it runs medially and parallel to the supraorbital nerve. And therefore, with the single injection or the puncture site, we can block both these nerves, allowing us to denervate or anesthetize this whole anterior aspect of the scalp. Here you can see after identifying the supraorbital foramen, the nerve, supraorbital nerve is blocked. Then the angle of the syringe is dropped down and the remaining portion of the needle is drawn medially inside. And additional 1 or 2 mils of local are injected to block the supratrochlear nerve through the same puncture site. After blocking the 2 nerves, this whole anterior area up to the vertex is blocked. Here you can see both nerves run parallel. We ask the patient to open eye, look forward, identifying the supraorbital foramen, which coincides with the pupil size. This is going to be our injection point. The injection is given just above the eyebrow. It is good idea to warn the patient that it is going to sting a little bit because this area is quite painful. And you can see with a single injection, both of these nerves can be blocked easily. This picture shows the probe positioning and orientation, which is placed just above the eyebrow. And both the nerves can be blocked by either in-plane or out-of-plane technique. After identifying the break in the supraciliary arch, which corresponds with the supraorbital notch, and usually the hockey stick kind of probe is used because this is a very high linear frequency probe. And for superficial structures like blocks, including the face and neck, this kind of probe is usually preferred. So after identifying the notch, Doppler is used to identify any vascular structures in the path, and then the needle is brought in medially in the in-plane technique, and then the local is injected just above this foramen to block both the supraorbital and the supratrochlear nerve. By blocking both these nerves, you can see the huge chunk of the anterior scalp is blocked. The supratrochlear is a smaller branch, but the supraorbital provides the main sensation to front of the scalp. The third one is the zygomaticotemporal nerve. It is basically the drug is injected above as well as below the temporalis fascia. The landmarks include identifying the lateral orbital margin over here, and just one finger breadth posterior to it is going to be our injection site. Another technique described is drawing a line from the anterior superior corner of the helix to the lateral orbital margin. And the middle of this line is going to be our injection site. We also need to be looking for any vascular branches of the superficial temporal arch in order to avoid vascular puncture or intravascular injection. Here, it is shown that identifying the lateral orbital margin, then one finger breadth posterior to it is going to be our injection point, which coincides with the superior border of the helix. And both superficial and deep injections are given to the temporal fascia. The same place is used for probe positioning in the transverse orientation. This picture should be identified. This is the zygomatic arch, and the injection should be given above and below this temporal fascia, because the zygomaticotemporal nerve gives a deep branch which pierces this fascia. And in order to block both these nerves, we need to give injection at both these sites. Here you can see the injection being placed, and a vascular structure has also been identified with the ultrasound. The fourth nerve is the auriculotemporal nerve. Now, there are a few approaches for this nerve. This picture very clearly shows the relation of the auriculotemporal nerve and the superficial temporal artery, which courses along with it throughout its course. One technique described is to block the nerve just in front of the tragus. Another technique is to draw a line from lateral canthus of the eye to the tragus. And 1 centimeter on this line medially, the nerve can be blocked. However, blocking the nerve at this lower location is associated with increased risk of facial nerve palsy as well. So, another technique is described to block the nerve at the level of the superior border of the helix. We palpate the superficial temporal artery and give the injection just behind it at the level of the superior border of the helix. If you place your finger in front of the tragus, you can very easily feel your superficial temporal artery pulsations. And so for a patient to identify these landmarks, it is very easy. This picture shows the injection site for blocking the auriculotemporal nerve. We should make sure that the injection is superficial and avoiding deep injections in order to avoid the block of facial nerve. This picture shows that a line is drawn from lateral canthus up to the tragus, and 1 centimeter anteriorly, the injection site is identified. And this lateral portion of the scalp can be blocked easily. Here is a clear demonstration of the two techniques. Here you can see that the nerve can be blocked at the tragus area, and this injection site is going to be below the temporomandibular joint and in front of the superficial temporal vessels. But again, as already mentioned, it is associated with increased risk of facial nerve palsy, so it is not a preferred technique. The preferred technique is this technique, this site where the pulsations are felt and the injection is placed just posteriorly at the level of the anterior superior border of the helix. We also ask the patient to open and close their mouth so that we can identify the temporomandibular joint, palpate it, and the injection is placed always above it at this level. Here you can see after palpating for the artery, the injection is placed just behind the pulsations, and a total of 3 mils is used to block the auriculotemporal nerve. You can also appreciate that the injection is being given intermittently with aspirations, which is very important to avoid intravascular injection in this region. For ultrasound guidance, here you can see the probe position, which is placed in front of the tragus, or it could be placed in front of the superior border of the tragus. And we need to use the Doppler to identify the superficial temporal artery. And the nerve lies just above it, where we can block it easily. Here you can see the superficial temporal artery is located. This is the pulsating structure, and Doppler is used to confirm the pulsatile flow. And after confirming the artery, the needle is brought in the in-plane technique, and the local is deposited just above the artery. Initially, here you can see the probe orientation and the placement of the needle. Now, initially, you can see that the nerve is not easily visible and cannot be appreciated. But after injecting the local anesthetic, now you can appreciate the nerve just above the artery. Here you can see it is very beautifully visualized. Okay, so regarding posterior auricular nerve, usually this can be omitted, but sometimes this tiny portion of the scalp may be involved in the incision site or the pin insertion site, and we need to block it separately. For blocking this nerve, we just need to move behind the auricle at the level of tragus and deposit 1 to 2 mils of local anesthetic. Another approach is to do a superficial cervical plexus block. What it does is that with the single injection, it helps us to block the lesser occipital as well as the great auricular nerves. So both these nerves are blocked, giving us the anesthetizing of this whole region of the lateral scalp behind the ear. Again, this picture shows that this whole area is going to be blocked by superficial cervical plexus injection. If you're doing the plexus block by landmark-based technique, you need to identify the mastoid process and draw a straight line up to the clavicle. This coincides with the posterior border of the sternomastoid muscle. Another line is drawn perpendicular to the first one at the level of thyroid cartilage. The point where both these lines coincide is going to be our injection site. The injection is given in a fanning technique, and the injection is usually superficial. We do not need to go deep in this part of the neck region. Here you can see that the fanning technique is used in order to block the superficial cervical plexus. The injection is superficial, and the clinician avoids deep injections. After blocking in the upward and downward directions, only the tip of the needle is drawn behind the posterior border of sternomastoid muscle, and an additional 1 to 2 mils is given. And you can get a superficial cervical plexus block. If ultrasound guidance is used, the probe is positioned in this orientation, transverse in the mid of the neck, and we need to identify this triangular structure, which is the sternomastoid muscle. And just below it lies the superficial cervical plexus, as denoted by these yellow arrows. And this is the position where we are going to inject 4 to 5 mils of local anesthetic to block the superficial cervical plexus. This whole strip shows the sternomastoid muscle, and this is the sonoanatomy for superficial cervical plexus block. Now, all this information may seem a lot to absorb, but once you get the idea, the whole of the scalp blocks hardly takes a couple of minutes to perform. Now, I would like all of you to visualize this video so that you may get the idea what I'm talking about. After gathering your supplies, and prepping and draping the patient, first of all, identify the supraorbital foramen, identifying the midline and going 2 cm laterally above the eyebrow. This is our injection site for blocking the supraorbital nerve. After giving 1 to 2 mils, the needle is drawn medially to block the supratrochlear nerve. Then the patient's head is turned to the side and a line is drawn from lateral orbital margin to the superior border of helix. And then the midpoint of this line is going to be our injection site for blocking the zygomaticotemporal nerve. After that, in front of the tragus, one finger breadth anteriorly, we are going to palpate for superficial temporal artery, and just behind this palpation and pulsation, we are going to block the auriculotemporal nerve. At the same level of tragus, but behind the auricle, great auricular nerve is blocked. Then posteriorly, the lesser and greater occipital nerves are blocked by the same technique as described by Dr. Umar, by drawing a line from the occipital protuberance up to the mastoid and dividing it into 3/3. We also need to identify the occipital artery there. For blocking these superficial cervical plexus, we identify the midline of the neck, mid of the neck, and we give the injection just behind the posterior border of the sternomastoid muscle. So you can see it is very easy and it just takes a couple of minutes to perform the scalp block on one side. The volume needed is hardly 1 to 2 mils for each nerve, except for the lesser and greater occipital, which may need up to 3 to 5 mils. This slide shows the summary of the landmarks for each nerve that I've already described. Now, there are some studies which show that for anterior craniotomy, you need to block just the anterior branches. And for posterior craniotomy, you need to block the greater and lesser occipital nerves only. However, I would like you to remind that the placement of the Mayfield pins and there may be extending of the incision, which could lead to discomfort to the patient. And most experienced clinicians advise to give the scalp block, including blocking all the 6 major nerves on both sides for every craniotomy. This provides with better results, better patient satisfaction, and higher comfort levels. There are certain situations where scalp block may not be indicated or is best avoided. The first one being the patient failing to give consent or not comfortable with the technique. And if there is a proven or suspected allergy to local anesthetics, if there is absence of bone flap due to craniectomy. Now remember, the bones act as our friends during the scalp block. And if a part is missing or there is a defect, we should not be performing the block in that area. Then the relative contraindications may include local site infections, bleeding disorders, and scarring due to previous craniotomy, which may lead to distortion of the anatomy and we might not get the expected results. Although quite safe, but still the craniotomy, the scalp block for craniotomy is an intervention and it is associated with some complications. For example, anaphylaxis in response to local anesthetics, toxicity of local anesthetic, hemodynamic changes and arrhythmias due to systemic absorption of either nor or of epinephrine or local anesthetics, vascular injury, hematoma formation, pain on injection, intraneural injection, facial nerve palsy, especially associated with auriculotemporal nerve block. Intracerebral and subarachnoid injection has also been reported in a single case report. Then it can also lead to bradycardia and hypotension due to trigeminocardiac reflex. I also saw a single case report of a patient developing unilateral ptosis because of the weight of the local anesthetic into the eyelid, which resolved after 24 to 48 hours. and although rare, but infection can also complicate the situation. Now I'm going to share a few practical tips with you based on practical experience of a lot of seniors. Starting with the basics, IV line is always maintained and informed consent should always be obtained in written. Oxygen availability and emergency drugs prepared in pre-filled syringes should be within reach at all times. Monitoring the patient at all times is of utmost importance. Even if you're planning for an awake craniotomy, you should always have all the drugs and equipment prepared to convert to general anesthesia if needed. Calculate the safe dose, volume, and concentration used, and it is preferable to use a separate syringe for each nerve. Regardless of whichever local anesthetic you're using, injection at multiple sites and selectively blocking peripheral nerves helps prevent absorption-related toxicity when compared to scalp infiltration. Selective blockade with minimal volume as opposed to ring infiltration allows for the use of maximal local anesthetic concentration, avoiding diluting it, which may benefit post-op analgesia as well. Epinephrine, as I've already mentioned, plays an important role not just in prolonging the block, but also helping with the hemostasis. Lidocaine is rarely used alone for scalp block. However, its more rapid onset of action is valuable for treating dural pain during the manipulation of the dura or frame placement in awake patients. Consistent with the vascularity of the scalp, the rate of rise of serum local anesthetic concentration is faster than other types of neuroblockades. And therefore, vigilant monitoring for local anesthetic systemic toxicity should be done during the first 15 to 30 minutes. In contrast to the toxicity observed from systemic absorption, the effects of direct intravascular or intrathecal injection are seen hyperacutely after only a few minutes of local anesthetic have been administered. Regardless of whatever the cause is, the resuscitation is same in all situations. In case of any complication, you should not panic and stick to your basics. Start with the ABC plan of resuscitation and always call for help. Manage the airway and hemodynamics until the patient is stable or help arrives. Always discuss the plan with your surgeon preoperatively about his approach, the approximate duration of the procedure, patient's position, and whether the surgeon is planning to change patient position during the procedure. This tip is for the beginners to inject for each nerve, both superficial and deep, to maximize your success rate, except for the auriculotemporal nerve to avoid facial nerve palsy. You can always supplement if there is sparing of a part involved in the incision or the surgeon can locally infiltrate. Remember, it is not considered a failed block. Now, usually a practical problem is seen, especially during awake craniotomy, and I'm going to provide a practical solution for that. We all know that the brain tissue is devoid of pain sensations. However, the dura mater receives its own nerve supply, is pain sensitive, and is not anesthetized by the scalp block. The dura is innervated by a lot of different nerves and branches, and it is impossible to block them all. In addition, during the infratentorial procedures, the sensory innervation to some parts of the brain is not subserved by distinct, readily identifiable peripheral nerves. This region represents a source of both intra and post-op pain. These issues are less appreciated for supratentorial procedures, but the pain that accompanies surgery can persist and become chronic for a very large variety of surgical procedures, and the neurosurgery is no exception to that. This phenomena is best established for posterior fossa procedures, for which post-op pain is rather common and may persist for many months, and it may be quite severe. So, the solution for this problem is dura block. What is dura block? Basically, once the skull is open and the dura is exposed, the surgeon infiltrates or irrigates the dura with local anesthetic, particularly lidocaine, owing to its shorter onset of action, and waits a few minutes so that the dura gets numb. So this is going to minimize the pain during the manipulation of dura or incision of dura. This targeted approach helps maintain patient comfort and cooperation. In some cases, additional local may be injected around the tumor or at other sensitive areas during the resection phase. Now, the neural blockade of the scalp may be used as an adjunct to general anesthesia or serve as the principal anesthetic for both intracranial and extracranial procedures. Meaning the scalp block can be used to supplement and be a part of multimodal analgesic technique during general anesthesia, or the scalp block may be the sole type of anesthetic used during awake craniotomies. Effective scalp block typically requires anesthetizing multiple peripheral nerves. And blockade of one or more of these nerves is used to diagnose and treat some chronic pain conditions as well. Improved anatomic knowledge has refined the use of scalp blockade so that directed neural blockade is achieved. The vascularity of the scalp, proximity of arteries supplying the cerebral circulation, use of larger volumes of local anesthetic, and presence of intracranial devices or bony defects requires special attention. The impact of peri-op scalp block on acute and chronic pain may offer insight into its benefits. And components of this block has recently emerged in treating some chronic pain conditions along with managing the posterior puncture headache. Regarding the awake craniotomy, there is an interesting case report that I would like to share with you. This was published in JCPSP, Journal of College of Physicians and Surgeons, and the authors claim that this is the first awake craniotomy done under scalp block in Pakistan. They reported a 53-year-old male weighing 90 kg, not known to have any other comorbid conditions, presented to the neurosurgical clinic with complaints of headache, blurring of vision, and gait abnormalities for the last 3 months. MRI revealed a left parieto-occipital space occupying lesion with 4 millimeter contralateral midline shift. Now you can see a huge area is involved, and we expect a larger incision for this patient. The neurosurgeon decided that awake craniotomy would be the best option for resection of this tumor as it lay just posterior to the main corticospinal tract. After routine pre-op assessment, the patient was taught in detail about the need of keeping him awake throughout the procedure. What should the patient expect during and after the procedure? The method of scalp block was explained, and the patient's own role was explained in the intraoperative care plan. Realistic counseling about possible discomforts like surgical positioning and dural pain was also done. Patient was also counseled about associated side effects. A PowerPoint presentation was used, which included necessary pictorial information related to scalp block, theater setup, and surgical positioning. This chart shows that they blocked the 6 main nerves of scalp on both sides bilaterally, and they used the landmark-based technique. This shows the landmark-based approach for each nerve. This shows the volume used on each side. 20 mLs for each side, and in total 40 mLs of local was used to block the whole of the scalp bilaterally. Along with that, 8 milligrams of DEXA as well as adrenaline was used as adjuncts. Again, I would to emphasize that although the incision was done on one side, but placement of Mayfield pins required that bilateral scalp blocks should be placed for every craniotomy. Additional local was also given on Mayfield pin site, and after evaluating the quality of block, patient was positioned laterally and pins were applied. Patient did not show any discomfort and remained pain-free throughout. However, mild to moderate pain was noticed because of dural traction during deep resection, which was very well managed with 10 mics of fentanyl boluses. Patient showed active involvement in intraop neurological monitoring, which was done to assess his contralateral motor and sensory functions. Higher mental functions were also evaluated during resection phase by asking questions related to memory. The total resection time was around 2 hours. After that, the patient was shifted to post-anesthesia care unit with stable vitals and then stepped down to special care without any stay in the ICU or requiring mechanical ventilation post-operatively. IV paracetamol and tramadol were prescribed for post-op pain relief. Patient remained fairly stable throughout the recovery period and was discharged to ward after 24 hours. Biopsy of the lesion showed it to be glioblastoma multiforme grade 4. After that, the patient was called on telephone after about 3 months to evaluate his satisfaction about the technique, for which he gave a score of 8 out of 10 on verbal rating scale. So, what do we take away from this case report? There are a few important points that I would like to add, and then I'm going to conclude my talk. The success of any technique is directly linked to patient selection and expertise of the team. Anesthesiologist plays a key role in the patient's psychological preparation. Along with routine assessment, it is important to evaluate patient's willingness and motivation. Identification of contraindications like inability to lie still, persistent cough, OSA, or history of any psychiatric disorder is quite important. The counseling should be realistic, where patients need to be reassured that they are going to be looked after by an expert team. However, it is also important to tell them about possible discomforts which may be experienced during the procedure. A close collaboration is required between the anesthesiologist and the surgeon, especially during the resection phase. Intraoperatively, some complications may occur which should be anticipated, like nausea, vomiting, or seizures, and the need to induce general anesthesia in emergency. Routine use of anti-epileptics and antiemetics should be the standard. Sometimes the surgeons used cold saline irrigation to stop seizures occurring intraoperatively. Most importantly, analgesia provided by scalp block needs to be bridged in the post-operative period, because even most of these seasoned clinicians fail to recognize the fact that the concept of patient care is that of a continuum with changing of hands or teams, but never a break or halt in between. Thank you.